So to introduce the panel, you already have heard from Duncan Selbie, Chief Executive of Public Health England. I'd like to introduce Dr. Muna Abdel Aziz, who is Director of Public Health at Warrington Borough Council. Professor Jamie, who we've just heard from, who's National Lead for Cardiovascular Disease Prevention and Associate Deputy Chief Nurse at Public Health England. And to my left, Dr. Matt Kearney, National Clinical Director for CVD Prevention, NHS England and Public Health England. And by no means, last but by no means least, Where am I? I'm so sorry, Dr. Matt Kearney, National Clinical Director.
Professor Steve.
Professor Steve Powis, I'm so sorry, Medical Director of NHS England, and I should know because I know you, I'm so sorry. So, shall we sort of go down the line? What do you think?
I'll respond because I've had the opportunity to
Okay, so Muna, if you'd like to start.
Thank you very much. And it's really great to see the ambitions, and it is a real call to action, because it sets us thinking about what we can each do individually, whether it's things that we control and influence within our sphere of work, but also within our public people relationships, social field, and so on. So the ambitions really, for me, stood out because the infographic and the video that we've seen are really hard-hitting, and they connect with people. I think that, because I come from a local authority background, I think that we all get prevention in our local settings, in the local place. We understand prevention. But within the existing sort of limited resources that we have, we may feel that we're kind of like halting or struggling a bit. And this is just a real push to say that it can be done. These ambitions are realistic and the targets can be achieved. It is just about how we work together to achieve that. I think that in Cheshire and Merseyside, because that's the area where I come from, we are already working as a system to make sure that we're working across partners with the third sector and making the best use of the resources that we have available. So I do really take this to heart, the call to action, that we should really consider what more we can do, because what we're doing isn't enough. What we're doing really isn't enough today, and it is the call to action to do more and to do better together.
Thank you. I'm going to leave you out of mine, I think. Matt, what do you think?
So we've been on a bit of a journey the last couple of years. We've had these conferences now. This is the 5th year. And we've all accepted that CVD prevention is important, and we know in this audience that population level measures are by far the most important, and support for behaviour change. But I think part of the journey we've been on is beginning to understand that there's so much we could be doing in the NHS, that we've got prevention we could be doing much better in our own backyard. And the focus on the high-risk conditions has come from that. Atrial fibrillation, high blood pressure, high cholesterol. We know how much better we could do with that. And I think the journey has been real, and we see it now from the long-term plan. The NHS actually does now get it. It realises there is scope for enormous improvement here. And we know that treating these high-risk conditions works, that, as we saw in the video, they do prevent strokes, they do prevent heart attacks. A year or so ago, we published the size of the prize, which I think for the first time helped SDPs and local authorities to see on one side of A4 just what was the potential for improvement in their area. And I think that was a bit of a game changer in helping people to move forward. And now we have the fantastic, really ambitious ambition in the long-term plan of 150,000 heart attacks and strokes. But this isn't going to be easy. This is a big challenge. This is an enormous challenge. We have the rule of halves that's been entrenched in general practice for 30-odd years. Improving the treatment of these conditions is actually difficult to do in general practice. So to rehearse the phrase that we've been repeating again and again the last couple of years, we have to do things differently. And what we're seeing now is key building blocks coming into place with the long-term plan, with the GP contract, with GP practices being working together in primary care networks, and they will have a focus on preventing cardiovascular disease at scale. With CVD Prevent, the audit, and now with the ambitions, the fantastic ambitions, that will help us all to keep a clear focus on the size of the prize. So I think it's been really welcomed and fantastic work.
And Steve, can I ask you?
Thank you. So I was at another conference, I think on Monday in London, which was the launch of Dr. Eric Topol's report on the effect of digital technologies, artificial intelligence, genomics on the future NHS workforce. And like many West Coast Americans, academics, when he stood up and gave his presentation, the first thing he showed was a lot of humility. And the reason he showed a lot of humility is that he put up an awful lot of slides showing why the NHS is the best healthcare system in the world. And it is, because very many learned bodies have done that analysis, and for many reasons across the breadth of what we need to deliver as a healthcare system, it comes out the best. But what he also showed is something that I also show, which is in one particular area we are not the best, and that's in health outcomes. And we're not the best in health outcomes in a particular range of areas. So respiratory disease, cancer outcomes, actually child mortality, we've been slipping behind. But one of the big areas, as you've heard, is cardiovascular disease. And so when the Prime Minister asked the NHS to produce a long-term plan in the summer, and we started to think about what needed to be in it, that was the reason. It was those analyses of what we are great at, but what we need to be better at, that drove our desire to put cardiovascular disease at the heart of the long-term plan. So I'm absolutely delighted that it sits there as a new strategic plan for NHS England. I'm also delighted because it means that in prevention is also the business of NHS England. It's not just the business of Public Health England, it's not just the business of local authorities, it is actually a core business of NHS England. So when we developed the cardiovascular strategy and the respiratory strategy and the stroke strategy as well, we very much thought of it in terms of prevention, acute management of an acute condition, and then rehabilitation. And of course, today we're thinking about prevention. And in all that work we did over the autumn, the easy thing was the what needs to be done. You've heard what needs to be done. You've heard what the gaps are. That doesn't take a lot of analysis. It is fairly obvious. The really difficult stuff is the how. How are we going to do this? And when I sit in meetings with Simon Stevens, the Chief Exec, and my executive colleagues at NHS England, what we really focus on and get grilled on is the how. Let's not talk about the problems we know about, let's talk about how we're going to fix them. And so if you read the long-term plan, what you will see that we've developed with our partners in Public Health England, with the British Heart Foundation, with the Stroke Association and others, is a set of interventions, a set of plans. And we've already started to hard-bake that into the way the NHS delivers care. So Matt mentioned the GP contract. So the GP contract, which was announced a couple of weeks ago, is a really important event because it really hardwires into our bedrock of the NHS primary care what the task is and what we need to achieve over the next 5 years. Work through with colleagues at the BMA and others, it sets out in a contractual term what needs to be done. And as Matt says, in that GP contract, you will see the provision of around 20,000 additional staff into primary care networks that will be doing this work. So pharmacists, physiotherapists, nurses, social prescribers, those are the people who will deliver this plan. Not on their own, but that's a substantial part of the how. We'll be starting recruiting them from this year. We have one of the 7 service specifications in that contract. Detailed is on cardiovascular disease prevention. That will start to kick off in a couple of years' time as those staff come in. So what really delights me about the long-term plan is not that we've identified the what, it's that we've laid out the how, and we have already started within the few weeks after the publication to hard-bake that in to our delivery mechanisms and what we all do on a daily basis in the NHS. And that's why I'm pretty confident, in fact very confident, that we will meet those ambitions that you've laid out today, because we're focusing on the how, not the what.
Thank you very much. Wow, okay. So do we have any questions from the floor? Yeah, wonderful. Give the microphone here. And if we take the second one to this gentleman over here, and then we can just be moving on fairly quickly. Have we got a third mic? Gentleman here and a couple of hands at the back there. So,
hi, my name is Ruth Pilton from East Cheshire NHS Trust. My question's about the role of wider community services. So we've recognised the need to identify AF. The GPs have started using the AliveCore device in our area, and we're currently put a bid in to purchase this device for community nurses. But how far do we go? How wide do we go without mentioned going back to basics, without preventing this from doing your core role, do we then get this for physiotherapists who are seeing patients, because we've got news too, they're going to start doing blood pressure monitoring and more, like how wide can you go with it taken away from the duties?
I don't mind starting. I think it's a really good question, and I mentioned during my presentation the British Heart Foundation are doing some really important work right now with a number of sites across the country to test different ways of how we identify people's risk. And so you talked about the traditional clinical kind of settings where we could be doing this in practice, in hospital settings, but the global case studies have also shown, for example, so Canada really has managed to turn around their detection and management, and most blood pressures are now done out of the office, so out of a clinical setting. So I think we do need to stretch and think about how we could do this in different ways. The commentary on the BBC this morning was very much, it's really difficult to know what your numbers are. And the other thing is, I think in the next couple of years, things will be revolutionised by digital and technology. So the availability, the way of doing this will just be on your phone. You won't even need to go to one of those settings. You've talked about a live call, and Matt was telling me about some tech he'd seen at Expo where they were developing blood pressure monitoring on phones. So and that will transform things significantly.
Thank you. Did you want to say something? No. Gentleman over there, yes, your question, sir.
Hello, thank you. Bit of feedback there, sorry. My name's Paul Rollins. I'm a general psychiatrist from Derbyshire, and I have to say I'm really impressed with this, and I love this conference. I've been to this conference for the last few years, and it's probably one of the favourite events that I go to. My question is about this issue of inequality, and the particular group where we see the most inequality is with people with serious mental illness. Now, it was a major error in my view when monitoring of glucose and cholesterol was taken out of the GP contract a few years ago. There's a new contract now, 2019, for GPs, I understand. What I'm interested in really is how that inequality within inequality of people with serious mental illness is going to be addressed, and what the views of the panel are.
Do you want to take that one?
No, well, I'm completely agreeing with you on every single level. People who have a mental health problem, add. If you're involved in the criminal justice system, add. The risks just escalate, and the gap between life and good health and expectancy between those with mental health problem and not, about 20 years. That's on top of the existing inequality. But I was wondering whether Matt had something to say about the GP contract. And,
well, yeah, you're absolutely right to raise this. And health inequalities is at the heart of the story about CVD prevention, because it's the single biggest driver, as we saw, of health inequalities. It accounts for a quarter of the life expectancy gap between rich and poor. So, to be honest, if we just do a lot better on CVD prevention, we will help health inequalities. But built into the ambitions is the challenge to make sure that we do more in areas of greatest deprivation, for example, so we tackle geographical inequality. But primary care networks are going to be key to this. Primary care networks are not just groupings of GPs. They are groupings, partnerships that will have an accountability for population health of 30 to 50,000. With CVD Prevent, the audit as it comes on stream, for example, we will be able to demonstrate, networks will know how they are performing across their population, how that compares with others, and what are the inequalities within that. We know that people with mental health problems, people with learning disability are much more likely to have cardiovascular disease and to die from cardiovascular disease at an early stage. Because we now have the strong narrative going forward in the GP contract around CVD prevention, I think it will be it'll be a cardinal focus for networks on how are we tackling health inequalities. And I think it'll be part of our role in providing national and local clinical leadership that we make sure we drive that. So I agree, we've really failed on this in the past. This is an enormous opportunity for us to make a difference on health inequalities.
I'll just throw back to you, Duncan.
One of the things that I think is really shifting is that we're talking about the difference between the rich and the poor, those who are affluent and those who aren't. And we've managed to get to this stage in our lives and talk about it as if it's some sort of issue. We use this about inequalities. We're talking about people who have the least that are suffering the most. And we know this. So this is, the point about we know this. The point is, what are we doing about it? And what's so strong about now? And I'm convinced of this, and I love this. I mean, this is the how are we going to do this? And the test for whether or not we've succeeded won't be some average, but about how we've dealt with those that are at the wrong end of everything. And so I think people with the mental health problems are a fantastic litmus test for whether or not we've made this happen. And the more we can talk about the difference between the affluent and the poor, it's not a moral issue or a political point. It's an economic question, as well as one that it's just not okay. It's just not okay, and we don't want to be talking anymore about what the problem is. It's about actually making sure that we're acting on it.
I mean, one of the first inequalities of mental health is that we have not been investing in mental health to the level that we've invested in physical health. And that matters when it comes to inequality of access for mental health. So that is why in the 5-year forward view and in the long-term plan, we will continue to drive that increased investment in mental health, because we know that people with mental health issues have poorer access and longer times to wait to get to see practitioners and healthcare professionals. So that's the first thing. The second, and that's not unconnected with the issue of inequalities. The second is that we need to rejoin physical and mental health an awful lot better than we've done. And we need to set about doing that as well. Third thing, learning disabilities is not mental health. Overlap, but it's not. But that's another group of people. Autistic spectrum. That's why there's a focus in that in the long-term plan, because we need to do better in those areas. So as Duncan says, you address some of these things by putting your money where your mouth is and investing those areas, and then with the interventions that mean that we use that resource to join up these things. And the final thing I'd say is one of the things that we really focused on in inequalities in the long-term plan was building an action to address inequalities into the interventions from the start rather than an afterthought. So for instance, when we start to roll out some of our atrial fibrillation programs, we will deliberately start targeting those towards areas where we know there is deprivation and there is the biggest inequality gap.
Okay. Can we get a couple of mics over there? But I'm just going to throw here, and if we can get time to all of you, we will do. Sir,
Dr. Butchi Reddy, Deputy Program Director, North West London Diabetes Transformation Program. This is an observation and a question. So the first observation is, I think Matt has mentioned public health is everyone's business, so which is quite important, and especially when we talk about accountable care systems and integrated care models. And so what is missing from all that is they include public health and local authority later on, or sometimes forget. So we just have to make sure, in case we move on to the next level, we are moving in North West London, so we want to ensure the public health is part of this collaboration, just as STP and others are. So that's one observation. The second one is, I think Jamie is probably doing more kind of a favor to the medical community rather than kind of thousands of clinicians checking their blood pressure and blood sugar and other things, because I think media awareness is very important. And so people are aware of pre-diabetes, pre-hypertension. Is there a term called pre-CVD? So I don't think so. So I think we need to invent a layman's term which becomes kind of catches with the public, and probably people take notice that the primary prevention is quite important. So it's just an observation that how the media could help the medical fraternity. So I've stopped practicing, so probably I'm doing more kind of justice to the healthcare system than when I was doing one-to-one kind of consultation. So I might say 10 to 15 patients in a day, but I think people can use their time much more effectively.
Thank you. That's certainly one for you, isn't it, Jamie?
So, yeah.
Oh,
well,
you
I'll
okay?
start off in
You
terms of...
start.
Thank you very much for the reference to public health and local authorities and our relationship into the NHS. And it's interesting that the earlier conversation around inequality was focused around inequality in accessing care. And that is also a prevention agenda that as public health we're engaged with. And we are working with our health and care partnership colleagues on the NHS to make sure that prevention opportunities are maximised at each step of a care pathway. Individuals with mental illness or with a learning disability would have an annual review at their GP. Whether they're accessing it or not is the question back about the causes of the causes and the deprivation and the ingrained, social determinants of health that may prevent someone from accessing care or from making a behavioural choice that, as Duncan has pointed out, many of these ambitions are about behavioural change. So I think that we are involved as local authorities in the causes of the causes, so working on housing, working on licensing, working on town planning, making sure that the public health grant around work, lifestyle support services are accessible and available. And we are prioritising those to the areas of most deprivation. But that's not where the health inequality story starts. It's actually not where it ends, because inequality in the inverse care law we've seen is compounded across the care pathway, primary care, secondary care, and tertiary care. So that's why we do need to work together as a system. And we have started to do this work on blood pressure. We're starting to do this work on atrial fibrillation and cholesterol through the CVD prevention work of the health and care partnerships. And this is replicated right across the country. So we are part of that system. But it really goes back to what is it that every individual here in this room and outside of this room can do for their own health and the health of others. And that's where the ambition, leading on to Jamie, the question that you did ask Jamie then, do we create a pre-CVD kind of term? So over to Jamie.
No, I think it's a really important question that you raise. And I think we're kind of starting to test some of this in things like the heart age test that we launched or relaunched last year. And in one day alone, we had almost 2 million people fully complete that online test. So the public are interested. They do want to know what their risk is, but we need to make it easier. We need to make it simpler. When I think back to when I was practicing, the countless consultations that I had trying to explain to somebody that they had a 18.5% risk of a heart attack or stroke over the next 10 years, and health professionals even struggle to understand that concept. But actually saying to somebody who's 40, you've got a heart age of 60, really hits home. And so I think we need to think more about how we can communicate this out. And again, as I said, the British Heart Foundation, others are looking at how we get that community mobilisation. The final thing I'll just say as well, I know our branding and marketing team in PHE, headed up by Sheila Mitchell, they're looking at this. So they're looking at this right now. Duncan will know that they're starting to think about how can we have a conversation with the public about knowing and understanding their risk. And that'll be something we'll be talking more about over the coming months or year.
Can I just have a show of hands as to the number of people in this room who've used the heart age tool? Yeah, those of you who haven't, do. I use it all the time in clinical practice. And even if people say to me, you might have 4 stone to lose, that's a mountain too high. But I'm probably skewing your figures slightly because I send people back to say, well, look, if you could just lose a stone, what would that do to your heart age? And it's an amazing motivator. We're going to take some more questions. Oh, sorry. Do you want to say something, Matt?
I was just going to say, we do get challenged about things like the heart age test and putting information out there. And it's almost a bit patronising from the medical profession. How will the public cope? We're going to upset them and worry them. The truth is, information is out there. People have access to lots of information now and want access to information. And I think we should embrace that, and we should democratise health information and get as much information out there as possible. And our roles as health professionals are changing to perhaps be more support to people on how to use that information and what to do with it. The answer is not head in the sand and to keep information from people. So I think we should really, really embrace this.
Thank you. We've probably only got time for 2 or 3 questions, but I can't see whether you're men or women back there, but there were 2 people who had their hands up right at the beginning.
Thanks, Chair. Rod Thompson, Director of Public Health for Shropshire. Question for the panel, but particularly for Duncan. And while I welcome the 10-year plan, I do welcome this initiative. I have to put a note of caution in. The grant to local authorities continues to be reduced year on year. making it harder for us to actually deliver some of the things that you've been talking about, Duncan. And there's an inequality that you haven't touched on, which is rural inequalities. Most of the rural local authorities receive significantly less per capita in the public health grant than urban areas. To give you a scale of the difference, Shropshire currently gets £38 per head of population against a national average of £58 per head of population. Kensington and Chelsea gets £131 per head of population. We have uncertainty about what will happen to the grant post-April 2020, and none of you so far have mentioned access to services in rural areas. Rural health inequalities is something that you and I, Duncan, have discussed on many occasions, and it is absent in any significant way from the 10-year plan. So I'd be interested to hear from both the Medical Director for NHS England and yourself about what collectively you will do to address rural health inequalities. Thank you.
Shall I take the first part? Of course, the inequalities in what each part of the country has been spending on public health predates the move back to local government, and if you like, there was a sevenfold difference between what one part of the NHS used to spend against another on these issues. I'm incredibly concerned that we're closing that gap, but we've had nothing but bad news in recent years about the level of funding that we've been able to distribute. More positively, we've been very, very supported by NHS England in making the argument that whilst the NHS can do more about placing prevention, I'm not going to articulate better than you did, Steve. I just thought that was... It isn't, of course, a substitute for proper investment in local government, proper investment in the wider determinants. I know that, you know that. It will be the biggest part of our conversation and priority for the spending review whenever that happens. I'm not going to try and I'm not going to speak to why a cut in the public health grant is not a good thing, and we've seen an almost 23% reduction over the last 5 years. That has an impact. We need to see that end, and we need to start seeing new investment.
So one interesting thing about the long-term plan, which I think is probably unique in the history of the NHS, which you may not have realised, but you probably know if you thought about it, is that this was a plan written by the NHS for government rather than a plan written by government for the NHS. And I think that's one of the reasons it's landed very well. But that did allow us, for instance, to call out some of these things. So the long-term plan is quite explicit in the requirement for funding, not just for Public Health England, but for social care and local government, and for Health Education England, and actually the capital budget, which was not part of the 3.4% settlement, and that those are really important parts of the jigsaw in the delivery of the long-term plan. So it's absolutely correct that in NHS England we can, to an extent, manage what we can manage within the budget of NHS England, and it was the 3.4% rise announced in the summer was for NHS England. But we also called out in the long plan, exactly as you said, this won't work in its entirety unless our partners in the delivery are also funded appropriately. Quite explicit about that. On rural areas, I think it is in the long-term plan. I have to go back and look, but it's a particular focus around access to healthcare in rural areas. So I'm not going to talk about local government so much, but back to problems of access to healthcare. Absolutely, we know that there are rural areas. I was down in Lincolnshire, in Boston, Pilgrim Hospital a few weeks ago. That is one of our most challenged healthcare economies when it comes to workforce, when it comes to providing care. We know that is a challenge. One of the other things I'm doing at the moment with colleagues is working on a workforce plan with Baroness Dido Harding that the Secretary of State and the Prime Minister's asked for. And one of our real focuses on there is how do we support the growth of the workforce in those rural areas? Because getting the workforce right, certainly in healthcare, is one of the ways that you start to fix some of those inequalities of access. I know that's not an answer firmly in local government, but I hope it reassures you as far as NHS England is concerned, we absolutely understand and have a focus on rural communities.
So the heart of this is we've conflated media, the public, professionals, all of us, that we can get good health through further and greater investment in the NHS. And our government has consistently prioritised that when there's new money to be had, it goes to the NHS. Now, that is a vital and necessary part of making things work, but it's not sufficient, and we know that. And what the NHS plan does is speak out on that. It calls it out, but it's a further example of government's investment being about a part of the system without having thought and considered the broader picture. To keep people well for longer, to help people to use the NHS less and later in life, to help people to stay in their own homes when they're unwell, to help people to stay in work for longer. These are all system things that the NHS can contribute to big, but they can't of themselves solve this. And so the argument about what we want to see through the next spending review will be about all of it. And what we've had is an early decision about the NHS, but it's not over yet. And I would argue that the issue is, of course, rurality. We know that, Rod, we know that, but we know at the very heart of the issue is deprivation. It's deprivation. It's not north or south or rural or town. It's about deprivation. It's where the deprivation is that we need to be getting the investment.
Thank you both. We've got time for 2 more questions. I know there's somebody at the back here, and I think the next person was somewhere over here. And then I think we could probably carry on doing questions all day, but we've got a packed agenda. So if we could go to the person at the back there, please.
Yeah, hello, it's Roy Maxwell from Public Health England. It's a question really about the availability and usefulness of NHS checks data. I suppose despite being in the target group, I had to ask for an NHS health check. As an analyst, Public Health England, in conjunction with the University of Sheffield, have developed the CVD ROI tool, which would rely heavily on NHS health checks data to make it useful outside of general practice level. But as far as I can tell, that data isn't available nationally for anyone kind of in a local authority or me as a researcher to use and make sense of the data. So that's the question. Is it going to be available, or have I missed something?
Yeah. So thank you actually for asking that question, because there's a huge amount of work going on from the team in PHE, Dr. Catherine Lagourde, who's in the room somewhere, and Slade Carter and others that have been working over the last, it's taken us almost 5 years to now agree with NHS Digital that we're going to take data, or in fact we have already taken data out of 90% of GP practices looking at the health check information. So all those people that have been invited, all those people that have received a check, what happens to them when they have a check, what happens to them after they have a check. So do they get referred into behavioural interventions? Do they get put on to disease registers? What pharmacological interventions are we using? And we will be publishing that data this year for the very first time, and it will be available to local authorities, to CCGs and other areas. So it's an important question, and one that we'll be responding to this year.
Thank you very much.
And could I just add to that, to flag CVD Prevent, which I mentioned a little while ago. This is a new, so the audit data you were describing will draw data from GP practices on what happens to people before, during and after the NHS health check. NHS England is going to commission a national CVD prevention audit for primary care, which will collect masses of routinely recorded data with no GP data burden, which will tell us in a practice or at network or national level how well we are doing in all of the high-risk conditions. There will be a lot of data there, and I think that's going to be extremely helpful for driving change and for driving improvement. At the moment, we're really data light in this area. We've got lots of data in the practices, but we don't really know how we're performing, and I think that's going to be transformative. And we hope that the first tranche of data will be coming within a year. And time will tell, but it is going to be commissioned, it is going to be developed. So I think that's a really exciting development along the road.
Okay, one last question over on my left. Over here.
My name is Steve Humphreys. I'm the Professor of Cardiovascular Genetics at UCL. I've been working on familial hypercholesterolemia for the last 30 years, mainly funded by the BHF. So I'm extremely excited and very encouraged to see this ambition in both PHE and the NHS long-term plan to find 25% of the FH patients in the UK in the next 5 years. The question is, how are we going to do it? If you want to know my ideas, come to the workshop 1C. But what's evident is we need nurses in the patient care pathway. The BHF have seed corn funded 29 nurses or so over the last few years, and the numbers that we found have gone up and up. We estimate we need about 150 nurses UK-wide in order to achieve that ambition. And when we go to CCGs and say, look, here's all the details, here's their cost effectiveness, this is what we need, they say, well, our main priorities are mental health, obesity, Alzheimer's, lower back pain. Which of those should we stop doing to fund your FH nurse? Can we get any help from the panel, please, about how we should incentivise and encourage the CCGs to fund FH nurses?
So I don't know, and I'll ask Matt to come in a minute, but I have a conversation with Steve, a colleague of mine at UCL, as to why we need a nurse specifically rather than another healthcare professional. But back to the GP contract, as I said, one of the reasons that's important is that provides the workforce and the funding, a substantial part of the funding, for that workforce that will be able to assist general practitioners. And of course, when you talk to CCGs, actually it's primary care that is going to be doing that. It puts that workforce into networks of general practices, serving around populations of around 30 to 50,000. Now, primary care is moving towards that in all sorts of parts of the country, and this is baking that into the contractual arrangements. But we think that is a sort of critical mass you need to be able to sustain that sort of additional workforce, whether it's a nurse or a pharmacist or a physiotherapist, who can help hard-pressed general practitioners with the additional work they need to do to detect not only patients or people with familial hypercholesterolemia, but people whose numbers are not known in the way that we've been describing. So I think the good news is that we have identified the workforce need, we've costed it, we've baked it into a contract, and now we will be rolling out the programs to use that workforce over the next few years to deliver on things like this.
I think the key is the recognition that none of this is easy. That's why we haven't progressed very much over the last 20 to 30 years. We've been able to articulate that for a long time. As Steve said, the difference now is that we're talking about the how. We're hardwiring changing. We have got some really crucial building blocks now in place. One of them, through the primary care networks, will be network service specifications. There will be 7 initially. The one on cardiovascular disease prevention will be tested over the next 2 years, but in 2 years, all networks will have a CVD prevention specification. And that will be specifically around identifying people with undiagnosed high blood pressure, high cholesterol, atrial fibrillation, drawing on the CVD Prevent data. They will have to show for their population, and they will get paid to do it, how they are organising services to make it happen. I think this is fantastic. This really is the how, and it's specific, and lots of detail will need to be developed, but it's going to be a contractual requirement with funding to follow. So I think it's for all of us now to get creative about how to make this work in practice.
I'm very happy to accept your offer, because you were being very inclusive as we go forward in developing these programs.
Wow, do you know, we could carry on for another hour or more. I'm sorry for the people that haven't had a chance to have their questions answered, but I think the fact that there are so many questions shows the real passion and interest in the room, and that's lovely. I know, Duncan, you've got to scoot off, I think, but the rest of the panel are around, and I'm going to volunteer them if people want to continue with their questions. Do you know, my overwhelming reaction to all of this is I qualified in 1987, so you're all quickly doing a calculation as to how old I am. old. And I think, to be fair, when I qualified, I worked in a national ILF service. You know, we very much responded to people who were poorly with symptoms. And it's only in recent years that I think we've really started to become a national health service. And what I love about everything I've heard today is, I think, Steve, you made reference to jigsaws. And I think in the past, everybody's been doing their own little jigsaw. And it really feels that now, for the first time, all the bodies that are involved in preventative health are starting to work on the same jigsaw. And I feel really quite buoyed up and excited about that. I think it's really great. So we're going to break in a moment. I would like to, can we do the feedback on the Mentimeter? Have we got the answer to the questions? Marvellous, prevention. Okay. So the next thing to say is we really do want you involved. I don't think you're going to take much encouraging. You've been very, very involved so far. But please, during the break, do take a moment to go and look at the posters and vote. Voting again is on Mentimeter, but this time you need a different code, and this one is 599201. So we'll pop that up on the screen for you in a moment. 599201. Jamie also mentioned the whiteboard. We'd really love your feedback on that, and do take some time to go and have a look at all the stalls that we've got. We're going to start again at 11:30. We've got a load to get through, so please, if everybody could be back in their sessions for 11:30, that would be great. And I think really now it just remains for me to thank you for your involvement, but also to thank our panel. Thank you very much indeed.